The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day everyone, I am Dr. Jed Llanes and I will be discussing your general pathology pearls. Remember that a good understanding of general pathology provides a foundation to understand the pathologies of different organ systems. So we'll be going through the chapters in Gen Patho by answering some high-yield questions. So let's start with cell injury, cell death, and adaptations. Prostatic enlargement from androgen stimulation is an example of which cellular adaptation. So prostatic enlargement is also known as prostatic hyperplasia. And hyperplasia means increase in number of cells. Now, hyperplasia yung hinahanap natin dito, so automatic mali na si A and B. Question na lang is, physiologic ba siya or pathologic? And the answer is actually pathologic hyperplasia. So let's discuss cell injury for a bit. So when a normal cell is either stressed or stimulated, it can either, 1, adapt, or be injured. So, nai-injure ang cell kapag hindi siya maka-adapt. Now, that injury, if it is mild lang, it's transient, it is reversible. So, nare-reverse, babalik siya sa pagiging normal cell. But if the injury is severe, it's progressive, then it becomes irreversible. And when you have irreversible injury, your cell can either undergo necrosis or apoptosis, your two types of cell death, your major types of cell death. So cellular adaptation, you have 4 forms. So tandaan lagi, gusto natin ng balance. So kung may stimulus, lalaki or dadami. Kung walang stimulus, liliit. So ano gagawin ng isang cell na hindi na kaya magparami ng sarili kung biglang kinailangan niya ng lakas or kailangan niya ng strength? Mag-increase siya ng size para makayanan niya yung added workload. Yun yung nangyayari sa hypertrophy. So there's an increase in cell size in cells that cannot divide due to increased workload. So you have physiologic and pathologic hypertrophy. Physiologic kasama dyan yung uterine enlargement during pregnancy kasi muscles don't divide. And pathologic kasama dyan yung heart enlargement in hypertension. Again, muscles can't divide. So they will hypertrophy to handle the increased workload. Kung kaya mag-divide, pag na-stress, edi dadami sila. So in cells that can divide, they increase in cell number. It's called hyperplasia. And usual stimulus for hyperplasia are your hormones and your growth factors. You have physiologic and pathologic. An example of your physiologic would be your breast acini or your cells that produce your milk, your breast acini, during lactation. So, pathologic example would be your prostatic hyperplasia or prostatic enlargement. Diba? Ang nag-stimulate nito ay your testosterone or your dihydrotestosterone. Kapag naman nawalan ka ng stimulus, whether it's decreased nutrient supply or hindi mo ginagamit, mag-atrophy. Kaya di mo naman ginagamit di tanggalin na natin or bawasan na natin. So there's atrophy, and atrophy is decrease in cell size or number. So it's again, the stimulus is decreased nutrient supply or disuse. You also have physiologic and pathologic atrophy. So physiologic atrophy is atrophy of your embryonic structures. Kasama dito yung notochord. Yan. Your pathologic atrophy on the other hand includes your muscle loss and prolonged immobilization. Di mo ginagamit yung muscles mo, so liliit sila ng size. And your senile atrophy of the brain. So habang tumatanda, nababawasan yung neurons mo through atrophy. Now, paano kung yung stimulus? Paano may stimulus pero yung cell type hindi niya kayang i-handle yung specific stressor na yon? So, for example, you have chronic irritation. The cell will undergo metaplasia or the tissues will undergo metaplasia. Now, in metaplasia, there's a change in phenotype of differentiated cells. Ngayon, yung cells ba themselves, yung mature cells ba, yung nag-iiba? Hindi siya nag-change from one cell type bigla to another. No. Ang nag-iiba is yung pag-differentiate ng tissue stem cells. So, yung basal cells mo, nag-iiba sila para pag nag-mature sila, magiging fit sila to handle that stressor. And the example here would be your columnar to squamous epithelia in chronic smokers. So, you have your columnar epithelia, which is your usual respiratory tract epithelia. Dahil sa chronic irritation, dahil sa smoke, nangyayari dyan yung stem cells mo at the base of the epithelium, sabihin nila, hindi natin kaya tong smoke na to. Kailangan natin mag-change. So, yung nagdi-differentiate sila into squamous cells which can better handle the smoke. Next, which is a characteristic of apoptosis? The answer here is nuclear fragmentation. So, denaturation of cellular proteins, excessive intracellular iron levels, and adjacent inflammation are not characteristics of apoptosis. Denaturation of cellular proteins, this is necrosis. Excessive intracellular iron levels, this is your ferroptosis. And adjacent inflammation, this is also a characteristic of your necrosis. So what are the characteristics ba of your necrosis and apoptosis, your two major forms of cell death? So this table summarizes your two major forms of cell death. So necrosis and apoptosis. And this summarizes their key differences. Remember, necrosis is usually pathologic and it's the culmination of your irreversible cell injury. So ayaw natin siya, it's unwanted, pangit siya. Pangit, madumi, magulo. So, cell size increases, the nucleus gets destroyed or nasisira, disrupted yung plasma membrane leading to leakage of cellular contents, at dahil nagli-leak yung cellular contents mo, nagkakaroon ka ng inflammation. So, frequent ang inflammation. On the other hand, apoptosis is programmed cell death. Programmed, basically, pag inisip mo, pwede ginusto natin siya or it's clean, it's nice. So, hindi siya magulo, hindi siya makalat. So, kapag may hindi na kailangan yung katawan natin na cells, i-eliminate siya through apoptosis. Kaya, it's usually physiologic. So, yung cell size, dahil sabi nga natin malinis, so yung cell size, lumiliit. Yung nucleus, hindi lang siya basta-basta nasisira. They become nucleosome-sized fragments. So, pinapackage pa siya into smaller pieces na mas madaling i-digest. The plasma membrane is intact, although yung alteration of structures is yung orientation of lipids, which is actually part of the signaling for apoptosis. And dahil intact ang plasma membrane, intact din yung cellular yung contents mo, and para ma-digest sila, pwede silang i-release in apoptotic bodies. So, everything is packaged in nice packages, at dahil walang leakage of contents, wala kang adjacent inflammation. So, malinis. So, basically, apoptosis, malinis. Necrosis, magulo. Yun yung mga key things na kailangan tandaan. There are also other forms of cell death, pero minor lang sila. You have necroptosis. So, necro and yung apoptosis. So, necro, morphologically similar to necrosis, but it's genetically controlled like apoptosis. So, mukha siyang necrosis, pero yung control niya ay parang apoptosis. You have pyroptosis, which occurs in cells infected by microbes, and it involves activation of caspase 1. And you have ferroptosis, which is an iron-dependent pathway. So, ferro is iron, ferroptosis. Next, a 57-year-old male was brought to the ER for severe crushing retrosternal chest pain. After several minutes, he suffered cardiac arrest and passed away. Post-mortem biopsy of his heart will show which finding. So now we're looking at patterns of necrosis. The correct answer here is letter A, coagulative necrosis. So your patterns of tissue necrosis are listed here. First, let's talk about coagulative necrosis. So coagulative necrosis yung nangyayari kapag namatay yung cells dahil nawalan ng blood supply, or yung tinatawag natin na ischemic necrosis. So wala masyadong inflammatory cells na nag-i-invade ng tissues. And itong coagulative necrosis, due to ischemic necrosis, happens in all organs except the brain. Kasi sa brain, di ba, liquefactive necrosis. So this is a gross um, a gross sample of a kidney that underwent ischemic necrosis. Itong white area na to, itong wedge shape, is called your infarct. So that's the infarct, and it's a localized area of coagulative necrosis. And if we look at this microscope slide of the infarct, makikita natin na dahil walang inflammatory cells, walang magdadigest ng dead cells initially, and yung injury, nasisira din niya actually yung enzymes that would actually digest your dead cells. So, the architecture, if you can look at this area, is preserved. So, makikita mo yung glomerulus, makikita mo yung mga tubules, etc. Preserved siya, usually for days to weeks. Nawawala lang yung architecture kapag nag-infiltrate na yung leukocytes. So, nagbe-breakdown na yung dead cells through their lysosomal enzymes and they remove them through phagocytosis. Next is your liquefactive necrosis. So, once you have digestion of dead cells, the area turns into a viscous fluid known as pus. So, the fluid in liquefactive necrosis is called pus. Kailan maraming pus? Kapag may bacterial or fungal infections. Kasi infections stimulate your leukocyte accumulation. So, your leukocytes digest your cells, they will produce the fluid, magkakaroon ka ng fluid, magkakaroon ng pus. So, pag maraming leukocytes, pus. So, usually, liquefactive kapag bacterial or fungal infections. Interestingly, seen in this picture, ito rin yung nangyayari sa ischemic necrosis of the brain. So itong area na to, ito yung necrotic part. And imbes na coagulative siya, na namumuo, para siyang nagiging buo, nagiging natutunaw siya, nagiging liquid siya. So again, digestion of dead cells turns, nagkakaroon ka ng viscous liquid known as pus. Bacterial or fungal infections, they stimulate leukocyte accumulation. Next, you have gangrenous. So gangrenous necrosis is not really a specific pattern of cell death. It's just usually applied to, it's a term applied to a limb that has lost its blood supply and undergone necrosis involving multiple planes. So as seen in this picture, meron tayong gangrenous necrosis ng foot, ng right foot. There can also be liquefactive necrosis actually on top of the gangrenous necrosis, lalo na kapag may infection, and this is known as your wet gangrene. So again, gangrenous, it's usually applied to a limb that has lost its blood supply. Tapos pwede siyang wet gangrene kapag infected. Next, you have caseous necrosis, which involves tuberculous infections. So yung itsura niya, itong caseous, kasi para siyang keso, cheese, and it has a friable white appearance. Friable and white appearance. On microscope, the necrotic area appears as a structureless collection of fragmented or lysed cells enclosed within a distinctive inflammatory border known as your granuloma. So, nasan kaya dito yung structureless collection of fragmented or lysed cells? Ito, yan. Yung mga walang nucleus, yung mukhang wala namang cell, yung mukha na siyang anggulo, yung wala namang cells na nakikita. And then, around it, marami kang inflammatory cells, nagbo-border dun sa area of necrosis. And itong buong to is known as your granuloma. Next, you have enzymatic fat necrosis or fat necrosis. It refers to focal areas of fat destruction due to release of activated pancreatic lipases. So, fatty acids generated combined with calcium to produce grossly visible chalky white areas. So, ito yung mga yan. Chalky white areas. So, fat digested by lipases combining with calcium generates these chalky white areas. And last, you have fibrinoid necrosis, which is specific to vasculature. So, it's a form of vascular damage seen in immune reactions involving blood vessels. So, anong mga immune reactions to? Ito yung mga antigen-antibody complexes na nagdi-deposit sa blood vessels in type 3 hypersensitivity reactions. So, yung immune complexes, they activate your complement proteins, resulting in inflammation in blood vessels, and they result in a bright pink and amorphous appearance on H&E stains. Yan. So, next chapter, inflammation and repair. Which cytokine is the major chemotactic factor for neutrophils? The answer here is interleukin-17. Para saan yung interferon gamma? This is for macrophage activation. Yung interleukin-2, it's for T helper cell recruitment. And interleukin-4 is for your Th2 response. So remember, remember and don't forget these very basic concepts about inflammation. Your 5 cardinal signs. So rubor, which is redness, calor, which is heat or warmth, dolor is pain, tumor is swelling, and functionalisa is loss of function. And remember your 5 general steps. So, the 5 general steps, actually, very intuitive naman kung isipin ninyo. Yung inflammation, kailangan una, meron kang agent na nagkakos ng inflammation. So, para magkaroon ng inflammation, kailangan ma-recognize mo yung agent na yon. Pag na-recognize mo na, kailangan mo nang mag-recruit ng mga mediators of inflammation mo to remove that agent. So, na-recruit mo na sila, tatanggalin na nila yung causative agent. Ngayon, gusto mo na yung nata-target lang ay yung offending agent. Ayaw mo ma-target yung normal tissues. So, kailangan ma-regulate mo yung response. And, ayaw mong tuloy-tuloy lang yung inflammation, so gusto mo mag-resolve din siya. So, the 5 R's. So, remember, recognition, recruitment, removal, regulation, and resolution. So let's go to regulation of response, and inflammation is regulated via the principal mediators. So you have your histamine, which produces vasodilation and increased vascular permeability. You have your prostaglandins, PGE, PGD, prostacyclin, PGF, which produce vasodilation, pain, and fever. You also have your leukotrienes, which produce increased vascular permeability, yung LTC, DE, and you have your chemotactic na leukotriene, yung LTB4. Then you have your cytokines, you have your which produce local and systemic effects. So local effect is endothelial activation. For systemic effects, you can have fever, metabolic abnormalities, and even lead to shock, like in cytokine storm. You have chemokines, which function as chemotactic agents and they activate your leukocytes. You have your platelet activating factor, you have your complement proteins, and you have your kinins. So quickly, let's just go through your arachidonic acid metabolites. So from your cell membrane phospholipids through the action of phospholipases, you produce your arachidonic acid. Through 2 pathways, through 2 enzymes, you have your cyclooxygenase pathway, which produce your prostaglandins, and then you have your lipoxygenase pathway, which produce your leukotrienes and your lipoxin. So prostacyclin and so cyclooxygenase pathway, you have prostacyclin, PGI2, which cause vasodilation and they inhibit platelet aggregation. You have your thromboxane, which cause vasoconstriction and promote platelet aggregation. So basically opposites si thromboxane at si prostacyclin. And you have your PGD and your PGE, which cause vasodilation and increase vascular permeability and even chemotaxis. Doon naman sa lipoxygenase pathway, you have your leukotriene B4, which is a chemotactic agent, and you have your leukotriene C, D, and E, which produce bronchospasm and increased vascular permeability. You also have your lipoxin A and B, which inhibit neutrophil adhesion and chemotaxis. So, just a few mnemonics. Arachidonic acid metabolites. Remember that all your prostaglandins, they vasodilate. Yun na muna. Prostaglandins vasodilate. You have a prostacyclin. So, it's, again, prostaglandins vasodilate. So, prostacyclin is a prostaglandin. So, it vasodilates. And yung in dyan is a inhibit platelet aggregation. Thromboxane, may A yan, capital A. Thromboplatelet A aggregation. So, platelet aggregation. E and D, they produce edema kasi nag-vasodilate tapos nag-increase vascular permeability. So, edema, PG, edema. LTB, it brings in leukocytes. And CDE, sedema. So, CED, edema. Sedema kasi increased vascular permeability. Next, you have your cytokines. So let's just go through some of your more common ones. So in acute inflammation, you have tumor necrosis factor, you have your interleukin 1, interleukin 6, you have your interleukin 17. In chronic inflammation, you have your interleukin 12, interferon gamma, and interleukin 17. Tumor necrosis factor, it stimulates the expression of endothelial adhesion molecules and secretion of other cytokines. Interleukin 1, similar siya to TNF, but ito yung important, it has a greater role in fever. So, interleukin 1, fever. Interleukin 6, it has systemic effects. It's part of the acute phase response. And for interleukin 17, remember, it's important in the recruitment of neutrophils and monocytes. For chronic inflammation, your interleukin 12 increased production, it leads to increased production of your interferon gamma, and your interferon gamma activates your macrophages so that it can kill microbes and tumor cells. Next, which complement proteins are involved in disrupting membrane integrity by drilling holes through the lipid bilayer, causing osmotic lysis of cells? The answer here is C5b, C6, and C6 to C9. These are known as your late-acting complements forming your, anong tawag dito? This is your membrane attack complex. Now, C3a, C4a, and C5a, these are your anaphylatoxins. They promote histamine release from mast cells. So, they promote inflammation. C3b, yan yung important na for phagocytosis. Yeah. Okay? So, your complement system, you have 3 pathways that activate them. You have the classical pathway wherein an antibody binds to an antigen, which activates the complement system. Your alternative pathway is yung microbe derecho. Then you have your lectin pathway wherein there's a mannose binding lectin. So all of them lead to C3b being deposited on the microbe. Now, once C3b is deposited on the microbe, it leads to several effector functions. So your C5a and C3a, they lead to inflammation. Your C3b, yung presence mismo ni C3b, makes the microbe very palatable or very yummy dun sa mga two phagocytes. So, C3b leads to phagocytosis. And C3b also leads to the effector function of C3b also leads to the formation of your membrane attack complex. Again, your C5a tapos then C6 to C9. They promote to cause the lysis of the microbe. So, 3 outcomes: inflammation, opsonization or yung promoting phagocytosis, and cell lysis. Again, for inflammation, you have C3a, C4a, and C5a, your anaphylatoxins, which promote histamine release from mast cells. You have C5a, which is a chemotactic agent, so leukocyte recruitment. C3b, it promotes phagocytosis, and your membrane attack complex for cell lysis. So, mnemonics, paano natin tatandaan to? So, complement proteins, you have C3a, C4a, and C5a, anaphylatoxins. So, wala na anaphylatoxins. C5a, meron siyang second na function. So, C5a, C5, 5 letters chemo, tapos 5 letters then taxis. So, chemotaxis. So, yung isa pang pwedeng mnemonic sa C5, kung mas familiar kayo, sa C5 may mga taxi. And it helps bring the leukocytes to the site of inflammation. So, chemotaxis. C5b, opsonization, 5-gocytosis. So, C5b, opsonization, 5-gocytosis. Tapos, C5b, C6 to C9, ang daming complement, napaka-complex, membrane attack complex. Okay? Now, let's go to hemodynamic disorders. So, what is the mechanism of edema in ascites? you have impaired venous return. So sa ascites, hindi nakaka-return ng maayos yung blood from your portal circulation back to your inferior vena cava, to your heart. So pag naipon na yun sa baba, ay dun sa splanchnic circulation, magkakaroon ka ng increased hydrostatic pressure. At dahil nag-increase na hydrostatic pressure, lalabas yung fluid. So it's not reduced plasma-osmotic pressure, although kapag mayroon kang liver cirrhosis, most likely bumababa din yung production ng albumin, pwede ka rin magkaroon ng generalized edema. It's not arteriolar dilatation, it's also not sodium retention. So when fluid accumulates in the tissues, it's known as edema. Kapag sa body cavities, it's known as effusion. Just remember your net filtration pressure to know what contributes to edema. So you compare the forces that make the fluid stay in your capillaries versus all the forces that make the fluid go out of the capillaries. So ano ba yung mga forces that make the fluid go out? You have your capillary hydrostatic pressure. So yung force ng blood, yun, acting on the walls, palabas. And dito sa interstitium, you have your interstitial oncotic pressure. So it pulls. So something pulls the water out. And yung mga paloob, you have your interstitial hydrostatic pressure. So from the interstitium papunta dun sa vessels. And you have your plasma colloid osmotic pressure. So yung capillary oncotic pressure. Yan. So, kapag sinamap mo yan, tapos nun mas malakas yung one side over the other, dun pupunta. So, in edema, ang nangyayari dyan is masyadong malakas to na hindi nalalabanan to. Or masyadong mahina to na hindi nalalabanan to. So, naiiwan sa labas yung fluid. Pwede ka rin magkaroon ng block. One other thing is, magkaroon ka ng block dito sa lymphatics which drain the excess fluid in the interstitium. So, maiipon lang siya sa interstitium. So, if there's increased hydrostatic pressure in the capillaries, decreased oncotic pressure in the capillaries, decreased hydrostatic pressure in the interstitium, or increased oncotic pressure in the interstitium, or lymphatic blockage, there will be fluid accumulation. And this diagram shows the different mechanisms of edema. So, kung sa heart failure, hindi nag-flow na maayos yung dugo, so there naiipon yung dugo, there will be increased capillary hydrostatic pressure. There will also be decreased renal blood flow dahil mababa yung blood flow sa kidney, sa kala niya, kailangan niya ng mas maraming fluid, kailangan ng retention ng fluid, so ma-activate yung RAAS, magkakaroon ng sodium and water retention, tataas yung blood volume, magkakaroon ka ng edema. So, capillary hydrostatic pressure, increased blood volume. Tapos, pag may malnutrition ka, decreased hepatic synthesis of proteins, and yung nephrotic syndrome kung saan naglalabas ka ng mga proteins, di-decrease plasma albumin, mag-decrease plasma osmotic pressure, which also lead to edema. So these are the pathophysiologic categories of edema. So increased hydrostatic pressure, reduced plasma-osmotic pressure, lymphatic obstruction, sodium retention, and inflammation. Sa increased hydrostatic pressure, pwede kasi siyang impaired venous return, so naipon yung dugo sa veins, or pwede rin siyang arteriolar dilatation. So sa impaired venous return, dito yung mga very common na nakikita natin: congestive heart failure, ascites, venous obstruction, lower extremity inactivity with prolonged dependency. So usually kapag impaired venous return, kung saan naiipon yung veins, doon lalabas yung fluid. So kung sa congestive heart failure, kung hindi yung buong venous system ay defective, sa dependent portion siya. So sa legs. Sa liver cirrhosis, sa ascites, sa dito siya sa may abdomen natin. Sa reduced plasma osmotic pressure or hypoproteinemia, kasama dito yung mga protein-losing glomerulopathies, yan, nephrotic syndrome, naglalabas ka ng mga proteins. Liver cirrhosis, kasi hindi ka nakakapag-produce, reduced production of your proteins. Malnutrition, wala ka ring enough to produce your proteins. Yung mga yan, mas generalized yung edema nila. Next, disseminated intravascular coagulopathy will present with which laboratory parameter? The answer here is decreased fibrin. So actually, in DIC, this will be decreased platelets, you'll have decreased factor 5, and increased plasmin. So ano nga ba yung nangyayari sa DIC? Pero to know kung ano nangyayari sa DIC, let's have a quick discussion of normal hemostasis. So, dito sa first picture, makikita natin na after vascular injury, ang unang mangyayari ay reflex vasoconstriction. May neurohormonal factors ka producing that. Next, you have primary hemostasis. So what happens is the platelets will adhere via their glycoprotein 1B receptors to the exposed von Willebrand factors na nandun sa extracellular matrix. So, kapag na-attach na sila, nag-adhere na yung platelets, mag-activate sila. Kapag nag-activate sila, they will undergo shape change and granule release. Released adenosine diphosphate and thromboxane A2 induce additional platelet aggregation. So, granule release, increased platelet aggregation through their GP2B3A naman. So, magbabind sila sa isa't isa through their magbabind sila to fibrinogen to form your hemostatic plug or your primary clot. Next, you have your secondary hemostasis. So, local activation of the coagulation cascade involving your tissue factor results in fibrin polymerization, cementing the platelets into a definitive secondary hemostatic plug. And lastly, counter-regulatory mechanisms. So, you have your TPA for fibrinolysis, and you have your thrombomodulin to block the coagulation cascade. So, medyo nire-regulate mo na yung pag-form ng clot. Kasi syempre, ayaw mong tuloy-tuloy yung pag-form ng clot kasi magbabara. Now, what happens in DIC? So, in DIC, there's massive tissue destruction, release of products of conception, sepsis, or endothelial injury which trigger the release of tissue factor. Ngayon, kapag widespread talaga siya, magkakaroon ka ng widespread microvascular thrombosis. So, mauuna ay thrombosis. Dahil na-activate yung tissue, nag-release ka ng tissue factor, mag-activate yung coagulation cascade, meron ka ng mga platelets na mag-aggregate, etc. Dahil magkakaroon ka ng widespread microvascular thrombosis, merong tatlong mangyayari. Ma-activate si plasmin, magkakaroon ka ng vascular occlusion, and mako-consume lahat ng clotting factors and platelets. Kapag na-activate si plasmin, magkakaroon ka ng fibrinolysis, magkakaroon ka ng fibrin split products, and dahil sa fibrin split products, may inhibit mo yung thrombin, platelet aggregation, and fibrin polymerization. So basically, hindi ka maka-form ng yung clots. Yung vascular occlusion, magkakaroon ng ischemic tissue damage, and yung pag-consume mo mismo ng clotting factors and platelets, dahil yun nga, nagkaroon ka ng widespread microvascular thrombosis, so nagamit na sila lahat, magbi-bleed ka. So, meron kang factors na nag-inhibit ng pag-form ng clot, at also wala ka ng panggawa ng clot. So, magkakaroon ka ng bleeding. So, clotting factors and platelets are decreased. So, di ba, decreased platelet dapat and decreased factor 5. Bleeding parameters are increased. So, mas matagal kang nagbe-bleed. So, bleeding time is increased. And there is increase in plasmin and fibrin split products. Next, which type of shock is associated with low blood volume? Remember that shock is a state when there is reduced effective circulating blood volume, which impairs tissue perfusion and causes tissue hypoxia. So, sa tingin ninyo, kailan kayo magkakaroon ng mababang effective circulating blood volume? Kapag wala kang blood volume or kapag hindi gumagalaw yung blood mo. So, kapag wala kang blood volume, that's hypovolemic shock. So, the answer is letter C. So, the major types of shock differ in their principal mechanisms. So, according to Robbins, this is Robbins, hindi to Harrison's. So, you have three. So, cardiogenic, hypovolemic, and shock associated with systemic inflammation. So, cardiogenic shock, there's a failure of your heart to pump blood. So, naiipon yung dugo. So, hindi nakaka-flow, hindi maayos, so hindi na de-deliver yung nutrients or oxygen, so tissue hypoxia. So, yung mga pwedeng dahilan bakit nagfe-fail yung pump, pwedeng intrinsic, so yung heart muscles hindi nagpa-pump like in MI, extrinsic compression, kung meron kang cardiac tamponade, pwede ring obstruction to outflow. Next, you have your hypovolemic shock. There's inadequate blood or plasma volume, hypovolemic. Low volume of blood. So, kasama dito, fluid loss, pwedeng hemorrhage, pwedeng water loss from vomiting, diarrhea, burns, or trauma. Yan. And you have shock associated with systemic inflammation. So, kapag systemic inflammation, ang nangyayari dyan, meron kang peripheral vasodilation and pooling of blood. So, lahat nasa periphery kasi nag-vasodilate lahat. So, hindi na effectively na bababa yung blood pressure mo, so hindi rin nakakadaloy na maayos yung dugo. And usually nangyayari siya when you have activation of your cytokine cascades. It also happens in disseminated intravascular coagulation. Examples would be overwhelming microbial infections, so sepsis, superantigens, toxic shocks like in toxic shock syndrome, and trauma, burns, and pancreatitis. Although meron kang less commonly less common types of shock. You also have your spinal cord injury or your neurogenic shock, or pwedeng IgE-mediated hypersensitivity reaction or your anaphylactic shock. So, medyo kamukha lang siya nung systemic inflammation. It's acute vasodilation leading to hypotension and tissue hypoperfusion. Now let's go to genetic disorders. So mutations are permanent changes to the DNA. They can lead to hereditary diseases if your germ cells are affected, and cancers and congenital diseases if the somatic cells are affected. So these are the general principles of mutations. You can have point mutations within coding sequences. So for example, TGC. Yan, kunwari ganyan. Dahil nagkaroon ka ng may isang magbabago to kunwari, sabihin natin naging A siya. So nag-iba na yung pag tinranslate to at pag tinranscribe at tinranslate, mag-iiba na yung mapoproduce niyang protein dahil nagkaroon ka ng change sa isa. You can also have mutations within non-coding sequences which are important for regulation of gene expression. So, kung nag-iba yung non-coding sequence important in the expression of a certain gene, either magkakaroon ka ng marked reduction in the transcription or total lack of transcription. Pwede yun. Kapag naman nagka-deletions or insertions sa coding sequence, may two possible effects sa encoded protein. So, kunwari, yan, kunwari ganyan. So, kung nag-delete ng tatlo, nawala yan. Or nag-insert ng bagong tatlo, sabihin natin nag-insert dito ng bago, GGA. Kung nag-insert ng bago, dahil intact yung reading frame, kasi nga every 3 yung pagbasa nung mRNA, pwedeng magkaroon ka lang ng abnormal protein or pwedeng dahil may extra or bawas na amino acid. Pero kapag non-multiple of 3 yung na-insert or na-delete, magkakaroon ka ng frame shift mutation. So meaning mag-iiba yung reading frame. So kung yung natanggal dito sa part na to ay itong TG lang, so imbis na TGC, ATG, ang mangyayari dyan, CAT na yung first protein mo or yung first basa. So, frame shift mutation ang tawag doon. So, they usually result in incorporation of a variable number of incorrect amino acids, followed by truncation, resulting from a premature stop codon. Coding genes can also undergo structural variations such as copy number changes, amplifications, deletions, etc. And you also have alterations in non-coding RNAs. Tas meron ka rin yung trinucleotide repeat mutation. So, dyan yung amplification of a sequence of 3 nucleotides. So, karamihan dyan yung na-affect ay guanine and cytosine. So, kunwari yung sa Fragile X, CGG, Friedreich ataxia, GAA, Huntington, CAG. So, next, what is the hemoglobin of patients with sickle cell disease? The answer here is HBSS. So, ito, ibig sabihin nito actually is homozygous ka. Homozygous ka for the sickle cell trait. Ito, homozygous ka for the sickle cell gene. Ito, ibig sabihin, sickle cell trait ka lang. Heterozygous ka. HbF, it's your fetal hemoglobin. And HBC is a variation of your sickle cell disease. So, pag sickle cell disease, kailangan homozygous ka. So, HBSS. So, remember that hemoglobin is a tetrameric protein with 2 pairs of alpha and beta globin chains. In sickle cell anemia, meron kang point mutation sa beta globin gene such that yung napoproduce na amino acid, yung napoproduce sa sequence, ibis na may glutamate doon, yung isang glutamate nagiging valine and it's called your missense mutation. Now, you have genotypes of your hemoglobin in sickle cell anemia. If you're normal, it's HbAA. If you're heterozygous for the trait, then you have sickle cell trait, it's HbAS, and in sickle cell disease, homozygous ka. Now, the pathophysiology is that dahil dun sa change from glutamate to valine, kapag na-deoxygenate yung RBC mo, nagiging sickle shaped siya. And once naging sickle shaped siya, it's more prone to membrane damage. At dahil pag nagkaroon na ng membrane damage, magkakaroon ka ng irreversibly sickled cells, so kahit na may oxygen, ganyan pa rin yung shape niya, which will lead to hemolysis. So nasisira na siya. Kapag na-oxygenate siya, babalik siya sa normal niya. Pero basta pag na-deoxygenate, babalik uli siya sa sickle cell form, at pag ganyan yung shape niya, hindi siya nakakadaloy sa microvasculature ng maayos, magkakaroon ka ng microvascular occlusion, which leads to your episodes of pain sa mga may sickle cell. Next question, what is the mode of inheritance of vitamin D resistant rickets? The answer is X-linked dominant. Vitamin D resistant rickets and Alport syndrome are one of the few major diseases that are X-linked dominant in inheritance. So let's go to transmission patterns of single gene disorders. You have autosomal dominant, autosomal recessive, and X-linked. Depende kung ano yung affected, your autosomes or your sex chromosomes. So familiar tayo sa Punnett square. So dito, sa Punnett square na to, these are your autosomes. Kapag autosomal dominant yung sakit, ilan yung chance na magkaroon ng sakit yung anak? It's 4 out of 4. Kasi mapapasa lagi yung yung dominant na allele. Ano yung chance na yung anak magkaroon ng kung autosomal recessive yung sakit, ilan yung chance na magkaroon yung anak? It's 0 out of 4. Pero kung let's say AA tsaka AA, so magiging half yung chance. Kung autosomal dominant, magiging half yung chance na magkaroon yung anak, half din yung chance kung autosomal recessive. Let's go to this part, yung X-linked. So, yung male, isa lang yung chromosome na nagkikarry ng trait. Sa female, 2. Pag dominant at may sakit yung tatay, mapapasa niya agad, automatic, yung dominant na allele sa lahat ng daughters niya. Kasi papasa niya X chromosome. So, automatic, lahat ng anak niyang babae, meron ng sakit na yon. Kapag yung nanay ay kapag X-linked dominant tapos non-heterozygous yung nanay, may chance na hindi mapasa doon sa isang anak. Kasi yung mabibigay niya ay yung recessive na allele. So autosomal dominant disorders, they usually involve your structural proteins. Very important dito, skeletal system, you have your Marfan syndrome and your Ehlers-Danlos syndrome, which we'll talk about later. Autosomal recessive disorders, they're usually enzyme defects. So usually, maraming metabolic. Yan. X-linked disorders, there are a few X-linked recessive. So kasama dyan yung hemophilia A and B, chronic granulomatous disease. You have sa immune, you have your agammaglobulinemia, Wiskott-Aldrich syndrome. Yan. But there are only very few X-linked dominant conditions. Kasama dyan ang vitamin D resistant rickets and your Alport syndrome. So let's talk about Marfan syndrome. What is the most life-threatening feature of Marfan syndrome? The answer is aortic rupture. Pero tandaan na meron din naman yung other choices. Meron kang MVP usually, pwede ka rin magkaroon ng pectus excavatum, pwede ka rin magkaroon ng ectopia lentis. Pero yung life-threatening ay yung aortic rupture. So Marfan syndrome is a defect in your fibrillin gene which produces fibrillin, which is a major component of your microfibrils. Specifically, important sila sa elastin, which allows structures to be very stretchy while still being able to return to its original shape. So, which structures are abundant in microfibrils and elastin? Yung mga kailangan mag-stretch tapos bumalik sa original shape nila. Kailangan mag-stretch to accommodate increased load. So kasama dyan yung aorta, ligaments, and your ciliary zonules that support the lens. So kapag affected sila, magkakaroon ka nitong manifestations na to. So sa skeletal system, these are usually your most striking feature. So ang palatandaan dito, kaya mo mag-stretch kasi nga kaya mo mag-stretch, pero dahil hindi marami yung Dahil may defect ka dun sa fibrillin, hindi sila nakabalik sa original shape nila. So, yun yung palatandaan. So, na-stretch pero hindi na babalik sa original shape. So, tall stature, long extremities, tapering fingers, lax joint ligaments. Sa head, pwede kang magkaroon ng frontal bossing, prominent supraorbital ridges. Sa spine, kyphosis, scoliosis. Sa chest, pwede kang either yung excavatum or carinatum. Sa eyes, again, dahil hindi na support ng maayos yung lens ng ciliary zonules, magkakaroon ka ng subluxation and it's outward and upward. So kung skeletal system manifestations yung most striking feature, ang most life-threatening ay yung cardiovascular manifestations. Kasama dyan ang mitral valve prolapse, severe aortic insufficiency, and aortic dissection and rupture. Isipin natin, dahil sa weakening ng tunica media, nag-stretch siya, parang hindi niya kayang mag-return to its original shape, magda-dilate lang siya. Tapos pag nag-dilate yung ascending aortic valve ring and aortic root, mag-lead siya to aortic insufficiency. Pag nag-weaken din yung tunica media, pwede kang magkaroon ng aortic dissection. Pag nag-rupture siya, yan, pwede mamatay yung patient. Next, a 28-year-old female presents at the emergency room with sudden, severe, tearing chest pain that radiates to the back. On obstetric history, the patient has a history of uterine rupture. On physical exam, the patient has thin, translucent skin, hyperextensibility of the interphalangeal joints, and bruising. The patient has a syndrome of which type? The answer here is letter D, type 4. This is Ehlers-Danlos syndrome. So, ano yun yung mga palatandaan natin? Alin dyan sa mga clues na yan? Well, ito. Yung severe tearing chest pain, that's aortic dissection. Meron siyang history of uterine rupture. Meron siyang thin, translucent skin, hyperextensibility of the joints, and bruising. This is Ehlers-Danlos na vascular type. So, Ehlers-Danlos syndromes, they result from mutations in genes that encode for collagen, or enzymes that modify collagen, or other proteins present in the extracellular matrix. So, it affects tissues rich in collagen, depending on the type. So, di ba, meron kang collagen type 1 sa bone, or sa tendon. Tapos meron ka rin yung collagen type 2 mo sa cartilage, kasi cartilage. Tapos yung type 3 ay sa retriculin. 4 sa floor, so basement membrane. Tapos you have your type 7 na mukhang anchor. Yan, di ba mukha siyang anchor? Yan, mukha siya nakasabit na ganun. Anchor. Mukha siyang anchoring, so anchoring fibrils. So, depending sa type of collagen, yung manifestation. So, your skin, ligaments, joints. Yan, type 1, type 2, yan, type 1, type 2. Blood vessels, intestines, uterus. Marami siya sa type 3 collagen. So, these are your classifications of your Ehlers-Danlos syndromes. So, your classic is 1 and 2. So, yan yung skin and joint hypermobility, atrophic scars, easy bruising. Your type 3 is hypermobility. So, hypermobility, pain, dislocations. Your type 4 is yung vascular. So, thin skin, arterial or uterine rupture, bruising, small joint hyperextensibility. Yung madali lang din tandaan is yung 6, yung kyphoscoliosis. So, meron kang, yan. So, may hypotonia, joint laxity, congenital scoliosis, ocular fragility. And, just a quick mnemonic. So, your classic, tandaan nyo lang. Ito yung kailangan tandaan. Classic ay 1 and 2. Hypermobile si 3, level up na siya kasi may extra siyang 1. So, hindi lang siya 1, hindi siya 2, 3 siya. So, level up. Mas hyper pa siya. Hypermobile ka sa usual mobility, extra mobility. Vascular, 4, IV line na nilalagay sa vessels. Vascular. So, IV, mas IV line, vessels. Kyphoscoliosis, madaling tandaan kasi 6. Yung 6 mukhang kuba. Ayan. Kung ito siya, tapos ito yung, yan. Mukha siyang kuba. Yan. So, 6 mukhang kuba, kyphoscoliosis. So, hypermobility, 3, vascular is 4. Classic yung 1N. Next, a 6-month-old male was brought to the ER for recurrent seizures associated with increased intervals between feedings and is not accompanied by fever. On physical exam, the liver is enlarged and there are multiple skin xanthomas. Further workup reveals hypoglycemia, hyperlipidemia, and hyperuricemia. Which enzyme is most likely deficient? So we have a 6-month-old male, recurrent seizures associated with increased intervals between feedings and not accompanied by fever. So, nirule out na agad natin yung febrile seizures. Increased intervals between feedings, ibig sabihin nun, during periods of fasting, tsaka siya nagkakaroon ng seizures. And most likely, given the lab workup, yung reason for the seizures ay yung hypoglycemia niya. So, meron kang hypoglycemia, hyperlipidemia, and hyperuricemia. So, we're talking here about an enzyme deficiency. And the most likely enzyme deficiency, kasi it does present with hypoglycemia, in fasting hypoglycemia, is your glucose 6-phosphatase deficiency. Kapag yung iba, hindi yan yung presentation. So you have your glycogen storage diseases. So they're inherited deficiency of enzymes involved in glycogen metabolism, which result in storage of normal or abnormal forms of glycogen. Usually sa liver or muscles kasi dito maraming glycogen, but also it can occur in other tissues as well. Ngayon, dito sa left, makikita natin yung glycogen pathway. So, glycogenesis and glycogenolysis. Part din dito yung yung glycolysis. So yung glycogen mo, i-breakdown mo siya during fasting, i-breakdown mo yung glycogen stores mo to produce your glucose. Para ma-mobilize siya, kailangan siyang maging glucose 6-phosphate, tapos kailangan matanggal yung phosphate kasi hindi siya makakalabas ng liver hanggat sa glucose 6-phosphate siya. So, kailangan mo si glucose 6-phosphatase para malabas siya. Tapos, meron ka ng glucose in the blood. Tapos, pwede na siyang gamitin ng other organs. Ngayon, kapag meron kang deficiency in your glucose 6-phosphatase, like your hepatic type of glycogen storage disease, also known as your von Gierke disease, ano nangyayari? Hindi makalabas yung glucose. So, magbe-breakdown si glycogen, pero dahil wala kang pang-release ng glucose na nakukuha mo sa glycogen, naipon lang siya sa liver. At kailan mo kailangan yung glucose yun? Kapag nagfa-fast ka. So, ano nangyayari? In untreated patients, you have hepatomegaly, you have urinomegaly, you have hypoglycemia due to failure of glucose mobilization. So, yun yung important na nangyayari. Hindi makalabas si glucose sa liver, so, hindi mo magamit si glucose. Hypoglycemic ka, often leading to convulsions. You also have hyperlipidemia and hyperuricemia resulting from deranged glucose metabolism, and many patients develop gout and even skin xanthomas. Diba sabi natin, maraming ang glycogen sa liver and sa muscle. So, pwede rin naman sa muscle affected. So, myopathic type of glycogen storage disease, you have deficiencies in your muscle phosphorylase. Pero dahil sa muscles lang naman affected, yung skeletal muscle lang yung nagbabago. So, ang nangyayari, painful cramps associated with exercise. Pwede ka rin magkaroon ng myoglobinuria. Pero yun, dahil hindi mo lang magamit yung glycogen na nasa muscles, hindi ka magkakaroon ng hypoglycemia kasi yung liver mo naman gumagana. So, yung glycogen stores ng liver, magagamit mo for glucose. Next question, a child with brush field spots will also most likely have. Kailan natin nakikita ang brush field spots? In Down syndrome. So, alin dyan yung makikita sa Down syndrome? It's your epicanthic folds. Web neck, usually sa Turner. Micrognathia sa Edward. Polydactyly sa Pataw. So, chromosomal abnormalities. So, you have your normal karyotype, 22 pairs of autosomes and 1 pair of sex chromosomes. So, you can have abnormalities in the number, called aneuploidy, or abnormalities in the structure. And it can involve your autosomes or sex chromosomes. So, for your autosomal cytogenetic disorders, you have trisomy 21, which is Down, trisomy 18 is Edward, and trisomy 13 is Pataw. So, for Down syndrome, usually yan, epicanthic folds, flat facial profile, yan, simian crease. Usually may umbilical hernia, you're predisposed to congenital heart defects, and intellectual disability. For Edward, you have low-set ears, you have overlapping fingers, renal malformations, rocker bottom feet, although rocker bottom feet, makikita mo rin siya sa Pataw, and you have your micrognathia. For Pataw, you have microphthalmia, you have polydactyly, you have clap, you have microcephaly, and again, you have your rocker bottom feet. Down syndrome, it's the most common. It's also a leading cause of mental retardation. Yung pinaka risk factor is isa mga pinakamalaking risk factor is advanced maternal age. You have diagnostic clinical features like your flat facial profile, your oblique palpebral fissures, and your epicantic folds. Other findings include your brush field spots, so nasa periphery ng iris, and your simian crease. So these are the affected systems in Down syndrome. So for CVS, you have ASDs, VSDs, and tetralogy of Fallot. So gastrointestinal tract, Hirschsprung disease, esophagus and small bowel atresia. You can also be predisposed with leukemias. So your most common is your acute megakardioblastic leukemia, CNS, early onset Alzheimer's, and immune system. Usually you have serious lung infections and thyroid autoimmunity. So some mnemonics for the trisomies. Down, trisomy 21. Kung gagana to sa inyo. Edward, 18. Trisomy 13 is unlucky. Pataw, patay. Next, aside from coarctation of the aorta, which congenital heart defect is most common in patients with Turner syndrome? The answer here is bicuspid aortic valve. So let's go to sex chromosome cytogenetic disorders. So they're more common and better tolerated. And they usually present with sexual development and fertility problems. And dahil sexual development and fertility problems, nadedetect siya at puberty. Examples, you have your Klinefelter, XXY, Turner syndrome, XO, hermaphroditism, and pseudohermaphroditism. So Turner syndrome, it's the single most important cause of primary amenorrhea. There's complete or partial monosomy of the X chromosome. So ano yung mga prominent features? You have webbing of the neck, you have broad chest and widely spaced nipples, and you have this streak ovaries, infertility, and amenorrhea. And also yung short stature yan. So pag nakita nyo sa case, short stature, web neck, yan, most likely Turner syndrome. Tapos yung complaint ay amenorrhea or infertility. Meron ka rin congenital heart disease, which is most frequently left-sided. So you have 2, preductal coarctation of the aorta and bicuspid aortic valve. Now let's go to the diseases of the immune system, which is absent once pathogens have infected the cells. The answer here would be intact epithelium. So paano nga ba makakapasok? Kung nakapasok na, edi na-breach na yung epithelium mo. Kasi syempre, yung epithelium mo, they line everything. Wala namang papasukan yan kung may intact yung epithelium mo. So pag nag-breach na yung pathogen, hindi na intact yung epithelium mo. Tapos kapag nag-breach na yung pathogen, tsaka na mag-activate yung mga inflammatory cells mo, neutrophils, macrophages, T cells. So absent na yung intact epithelium mo, which is a component of the adaptive immune system. The answer here would be your immunoglobulins. So you have your innate and adaptive immune system. So your innate lymphoid cells, your epithelium, and your membrane attack complexes are all part of the innate immune system. So your innate immune system, nakalist dyan kung ano yung mga parts. Yung key characteristic is that it's always the first line of defense. It's always present, and but it's less specific and less potent. See, adaptive, it's slower, it's later, it develops after antigen exposure, but it's more specific and more potent. Next, which co-receptor activates cytokine-secreting helper cells? The answer here is CD4. So let's talk about cell-mediated immunity. So you have your helper T cells, which stimulate B lymphocytes to make antibodies and activate other leukocytes to destroy microbes. You have your cytotoxic or killer T cells, which kill the infected cells. And you have your regulatory T cells to suppress immune responses. So T cell is activated via receptors. So these receptors are invariant in all T cells. So lahat ng T cells meron nito. T cell receptor, which recognize your antigens bound to the MHC molecules, and your CD3 complex. Now, you have co-receptors depending on the type of T cell. CD4 is found in your helper T cells and they bind to class 2 MHC molecules. CD8 co-receptor is found in your cytotoxic T cells and they bind to class 1 MHC molecules. Tandaan na rin natin na si class 1 MHC molecules ay present sa all self cells. Class 2 ay sa mga antigen-presenting cells. So, para madaling tandaan, di ba, CD4 times 2, CD4 is sa class 2 MHC molecules, equal lang siya sa CD8 na nagbabind sa class 1 MHC molecules. So, ito. Dito sa diagram, makikita yung T-cell receptor and yung, yan. So, ito yung T-cell. So, ito yung T-cell receptor mo. Yan. Ito yung CD3 proteins. Itong CD4, variable siya. So, this would be your CD4 T cell or your helper T cell. And magbabind siya sa class 2 MHC molecule sa antigen-presenting cell. So, you have 3 types of T helper cells. You have the TH1, TH2, and TH17. Depende rin kung anong napoproduce nila na cytokines. So, si TH1 is interferon gamma. And ano nga ba ginagawa ng interferon gamma? Macrophage activation. So, TH1 response mo, mag-activate ka ng macrophages na magpa-phagocytose ng mga infected cells, intracellular microbes. So, TH2 response, remember TH2, interleukin 4, so stimulation of IgE production, activation of mast cells and eosinophils. So, this is usually for your helminthic parasites and also allergies. TH17, diba? They produce IL-17 and IL-17 is for the recruitment of neutrophils and monocytes and these will destroy your extracellular bacteria and fungi. Next, which antibody fixes complement? So among the choices, the antibody which fixes complement there would be IgM. So let's talk about humoral immunity. So you have your B lymphocytes. These are the only cells which can produce antibodies by becoming plasma cells. So B lymphocytes, pag mag-mature, naging plasma cell to produce these. B cell activation. So parang sa T cell activation, meron kang receptors. So you have your surface immunoglobulins, IgM and IgD, to bind your antigens. You have your B cell receptor. You have CD21, which recognizes your complement products. And your CD40 recognizes signals from your helper T cells. So, so this is your humoral immunity in a nutshell. So, you have a naive B cell. Through the help of your helper T cell, they will proliferate and they will differentiate. So, pwede kang magkaroon ng antibody secretion, pwedeng mag-class switch, pwedeng may affinity maturation. Dito sa affinity maturation, dito mapoproduce yung memory B cells mo. Kapag na-produce na yung mga antibodies natin, meron siyang several functions. So, your functions of antibodies include neutralization, opsonization and phagocytosis, antibody-dependent cytotoxicity, you have complement activation. At pag nag-activate na si complement, yun na-discuss natin kanina na inflammation, opsonization and phagocytosis, and lysis of microbes. Remember that only IgM and IgG can fix complement. Next, which is true of the type of hypersensitivity reaction to which atopic bronchial asthma belongs. Atopic bronchial asthma is a type of what kind of hypersensitivity reaction? It's type 1. So, alin dito yung true sa type 1? Immediate release of vasoactive amines from mast cells? Yes, that's the correct answer. Lysis of targeted cells by activated complement proteins. This is type 2. Deposition of antigen-antibody complexes. This is type 3. Macrophage activation, granuloma formation. This is type 4. So you have 3 diseases of the immune system. At madaling tandaan, sobra, kulang, at bobo. Bobo kasi na-target yung sarili. So hypersensitivity reactions, immune reactions that cause injury. So sobra. Autoimmune, failure of tolerance to self-antigen. So, tinatarget mo yung sarili mo. Immunodeficiency, kulang. So, let's first talk about hypersensitivity. So you have your 4 types of hypersensitivity reactions, your immediate or type 1, antibody-mediated or type 2, immune complex-mediated or type 3, and cell-mediated or type 4. So sa type 1, yung mga nagkakos sa injury are your Th2 cells, Ig antibodies, and mast cells, and other leukocytes. Examples dyan, anaphylaxis, allergies, bronchial asthma. Sa antibody-mediated or type 2, you have your secreted IgG and IgM antibodies injuring cells by promoting their phagocytosis or lysis, and injured tissues by inducing inflammation. So meron kang phagocytosis, recruitment of leukocytes, promoting inflammation. But actually, pwede ka rin magkaroon ng functional derangements without cell or tissue injury. So, yung antibodies mo, magbabind siya to your receptors, causing the disease. Like, for example, your myasthenia gravis. Your immune complex mediated or type 3, you have IgG and IgM antibodies binding to antigens. So, nasa circulation, magbabind sila forming your complexes. Tapos, kapag nagkaroon ka ng complexes, magko-complement activation. Magkaka-recruitment of leukocytes, mag-release ng enzymes and other toxic molecules, etc. And if you remember our discussion kanina on necrosis, yung antigen-antibody complexes, when they deposit to your vasculature, nagkakaroon ka ng fibrinoid necrosis, necrotizing vasculitis. One very important example would be your SLE. And lastly, your cell-mediated immune disorder, your type 4, yung nagkakos ng injury are your T lymphocytes, your Th1 and Th17 cells, and your cytotoxic T cells. So examples of your immediate hypersensitivity would be anaphylaxis, bronchial asthma, allergic rhinitis, and food allergies. This diagram on the left summarizes kung ano yung nangyayari. So yung allergen papasok, madedetect siya ng dendritic cells mo, magbabind din siya sa B cells mo na merong IgE. Ngayon, ma-activate yung IgE secreting plasma cell to produce IgEs. Tapos noon yung IgEs mo magbabind sa mast cell, tapos yung mast cell pag nagbind na yung IgE mo sa mast cell, pag nagkaroon ka ng repeat exposure to the allergen, didikit siya dun sa IgE, tapos magre-release na yung mast cell nung mediators. So, you have your antibody-mediated hypersensitivity and yung mechanisms niya ay opsonization and phagocytosis, complement and Fc receptor-mediated inflammation, and antibody-mediated cellular dysfunction. So, opsonization and phagocytosis, kakainin yung cell. Inflammation, magkakaroon ka ng tissue injury dahil dun sa inflammation caused by your neutrophils, your enzymes, and reactive oxygen intermediates. Sa antibody-mediated cellular dysfunction, magbabind lang talaga yung antibodies dun sa receptors. Tapos dahil hindi nagbabind yung actual na ligand dapat, hindi gumagana. So examples dyan ay autoimmune hemolytic anemia, autoimmune thrombocytopenic purpura, you have your Goodpasture syndrome, and ito, myasthenia gravis and Graves' disease, ito yung mga antibody-mediated cellular dysfunction. Next, you have your immune complex-mediated hypersensitivity. So, ano nangyayari? You have your antigens in circulation, you have your antibodies. So, magkakaroon ka ng antigen-antibody complexes. Magbabind siya to your vessels, tapos magkakause na siya ng inflammation, mag-activate yung complement cascade, etc. So, magkakaroon ka ng immune complex-mediated inflammation and tissue injury, leading to vasculitis. So, examples dyan, systemic lupus erythematosus, post-streptococcal glomerulonephritis, you have your polyarteritis nodosa, reactive arthritis, serum sickness, and arthus reaction. Siyempre, pinaka-important dito would be your systemic lupus erythematosus. Yung antigen involved, remember, is your nuclear antigens. And lastly, your T-cell mediated hypersensitivity. So, you have cytokine-mediated inflammation dahil sa CD4 T-cells mo, and T-cell mediated cytolysis dahil sa cytotoxic T-cell mo. So, kasama dyan ng rheumatoid arthritis, type 1 diabetes, your inflammatory bowel disease, psoriasis, and contact sensitivity. Next, which is associated with inheriting the HLA-B27 gene. The answer here is reactive arthritis. Now, let's talk about autoimmune diseases. So, 2 factors in the pathogenesis that are important. You have your genetic susceptibility and your environmental triggers. Your genetic susceptibility leads to failure of self-tolerance. So, magpoproduce ka ng mga self-reactive lymphocytes. So, itong mga lymphocytes na to, pag nakawala sila, ita-target na nila yung tissues mo, yung normal tissues mo. Ngayon hindi sila nakakawala. Pero kapag nagkaroon ng environmental trigger like infections, inflammation, tissue injury, tapos nag-present na yung may trigger, may antigen ka, tapos na-present sila sa antigen-presenting cells, mag-release sila ng mga chemokines, cytokines, biglang na-attract yung mga self-reactive lymphocytes mo. At dahil nakawala na sila, they're free to target your normal tissues. So samples of your autoimmune diseases are listed here. Depende kung ano yung nagme-mediate. So kung antibodies, you have your hemolytic anemia, thrombocytopenia, yung kanina sa type 2 reactions, myasthenia gravis, Graves' disease, good pasture. You also have SLE. Meron ka rin yung mga mediated by T cells, yung mga nandun din kanina sa hypersensitivity, type 1 DM, rheumatoid arthritis, systemic sclerosis, and your Sjogren syndrome. So, regarding your HLA alleles and disease, the human leukocyte antigen system or complex is a complex of genes on chromosome 6 in humans which encodes self-surface proteins responsible for the regulation of the immune system. So, for HLA B27, yung associated disease would be your ankylosing spondylitis. Remember that. B27 is ankylosing spondylitis. But aside from ankylosing spondylitis, they're also susceptible to getting reactive arthritis from infections like your Campylobacter jejuni and Shigella. Next, kidney biopsy of a patient with SLE showed circumferential thickening of capillary wall due to subendothelial immune complex deposits in more than half of the glomeruli. This is what type of lupus nephritis. So anong clues natin dito? Meron kang subendothelial immune complex deposits more than half of the glomeruli. So do you think it's yung pagiging subendothelial, do you think it's sclerosing already? Yung more than half, is it focal? So the answer here is diffuse. So more than half, it's diffuse. Subendothelial immune complex deposits, makita mo yan sa focal and sa diffuse. So SLE is a systemic autoimmune disease. So meron yung mechanism of injury mo ay dalawa. Most manifestations ay dahil sa type 3 hypersensitivity, dahil sa immune complexes, but your hematologic manifestations ay dahil sa type 2 hypersensitivity reactions. So in your blood vessels, you have acute necrotizing vasculitis, diba? Fibrinoid necrosis nga dahil sa type 3 hypersensitivity. Sa kidneys, you have your lupus nephritis, which we'll discuss. Sa skin, remember your butterfly rash. In your joints, non-erosive synovitis. Your CNS, maraming manifestations, pwede kang magkaroon ng psychosis. In your body cavities, pwede kang magkaroon ng mga effusions. In your cardiovascular system, pwede kang magkaroon ng myocarditis, valvular abnormalities. Remember your Liebman-Sachs endocarditis? It's very specific to your SLE. Pwede rin matamaan ng spleen, lungs, and others. So let's go to lupus nephritis. You have 6. So first is minimal mesangial. Walang structural changes. Minimal. Mesangial proliferative. Mesangial cell proliferation. Sa immunofluorescence, yun lang, mesangial deposits. Kapag focal na, meron ka ng subendothelial immune complex deposit. So makikita mo siya, subendothelial. At dahil focal siya, less than 50% lang of the glomeruli. Kapag diffuse, subendothelial pa rin siya, pero more than 50% na of the glomeruli. Makakita ka rin ng wire loop structures. So circumferential thickening of capillary wall due to the immune complex deposits. Remember that your type 4 is the most common and most severe. Membranous, there's already subepithelial, and your advanced sclerosis of 90% of the glomeruli. Next, which term describes grafts of animal tissues transplanted to humans? The answer here is xenograft. So, xeno, animal. Ano yung allograft? Pag allo, same species. Auto, self. Iso, identical twin. Next, 5-year-old male was brought to the clinic for recurrent viral and fungal infections. Further examination reveals facial dysmorphism, developmental delay, and congenital defect of the great vessels, which is false about the syndrome affecting the child. So mukhang may syndrome. Nasa question na, may syndrome. So ano yung syndrome na to? So meron kang facial dysmorphism, developmental delay, congenital defect of the great vessels. Meron ka ring recurrent viral and fungal infection. So mukhang meron kang immunodeficiency. The answer here is letter B. Ano kayang syndrome to? And masasagot na siya nung letter A. This is the George syndrome. So, the George syndrome, meron kang may deletion ka of the genes sa chromosomal locus 22q11.2. Dahil dyan, meron kang lack of normal development of the third and fourth pharyngeal pouches. At dyan nanggagaling ang iyong thymus where your T cells mature. At dahil wala kang T cells, magkakaroon ka ng recurrent viral and fungal infections. Meron ka rin chronic hypocalcemia kasi dyan din nagde-develop ang iyong parathyroids. So let's talk about your immunodeficiencies. You have primary and secondary or acquired. So kapag primary, pwede kang may defect in your innate or adaptive immunity. So dito muna tayo sa innate immunity. So meron kang yung leukocyte adhesion deficiencies, your celiac Higashi, your chronic granulomatous disease, whether it's X-linked or autosomal recessive. You have myeloperoxidase deficiency. You can also have defects in your complement system, C2, C4 deficiency, C3 deficiency, and deficiency of complement regulatory proteins. Just a quick note on your chronic granulomatous disease. So you have decreased oxidative burst. So anong nangyayari, pwede kang may NADPH oxidase deficiency. So kapag kulang yung NADPH oxidase mo, hindi ka nakakagawa ng superoxides. And yung superoxides mo are important information of your agents which kill your bacteria. So dahil doon, wala ka nung decreased oxidative burst. So nagkakaroon ka ng, ang meron ka lang actually ay hydrogen peroxide. So yung hydrogen peroxide meron ka, pero kapag ang meron ka na lang ay hydrogen peroxide. Ngayon, kapag naka-encounter ka ng bacteria na gumagawa ng ng catalase which inhibits your hydrogen peroxide, wala ka na talagang defense against those organisms, like your Staph aureus. So next, you have your defects in adaptive immunity. So dito sa side na to, makikita natin yung defects in cell-mediated immunity. Dito naman yung humoral immunity. So focusing on this part, you have the George syndrome. So because of the chromosome 22q11 deletion, you have failure of development of your third and fourth pharyngeal pouches, leading to abnormal development of your thymus. So sa thymus, loss of T-cell mediated immunity. So susceptibility to fungal and viral infections. Parathyroids will lead you to will cause hypocalcemia, leading to tetany. Then your ultimobranchial body gives rise to your heart and great vessels. So you have your congenital defects of the heart and great vessels, abnormal mouth, ears, and fasces. So the famous mnemonic is catch-22. So cardiac abnormalities, abnormal fasces, thymic aplasia, cleft palate, hypocalcemia or hypoparathyroidism, and 22q11 deletion. Next, a 14-month male was seen at the ER with cough, tachypnea, tachycardia fever, and decreased breath sounds on auscultation. The patient also has a history of repeated ear infections and pneumonia after 6 months of age. Workup revealed below normal levels of IgG, IgA, IgM, and IgE. What is the most likely diagnosis? So, dahil mababa lahat, tanggalin na natin si isolated IgA deficiency. Kapag severe combined immunodeficiency, most likely magpe-present siya at an earlier age, pati yung common variable immunodeficiency. At 14 months, wala ka na kasi nung antibodies na galing sa mother. So, this would mean that the lack is sa humoral immunity. So, below normal levels nga naman yung mga antibodies. So, mukhang hindi naman affected masyado yung cell-mediated immunity. humoral immunity lang talaga. So, the answer here is X-linked agammaglobulinemia. So, again, pag tingin natin dito, X-linked agammaglobulinemia ay nandito. So, defect siya in your humoral immunity. It's also known as your Bruton agammaglobulinemia, where there is a defect in your BTK gene leading to failure of B-cell maturation. So, respiratory and GIT infections, kasi syempre wala kang IgA that lines your epithelium to protect you from bacteria or viruses. So, respiratory and GIT infections at about 6 months of age kung kailan nawawala na yung maternal antibodies. Absent B-cell and plasma cells, low levels of all antibodies, but you have normal T-cell mediated reactions. Okay? Now let's go to neoplasms. So malignant tumors arising from connective tissues are called sarcomas. Adenoma and fibroma are benign, while carcinoma is malignant epithelial tumor, not connective tissue. So some terms in nomenclature: neoplasia, new growth. Neoplasm is a collection of cells and stroma of new growth. Parenchyma are your neoplastic cells. Your stroma is yung mga adjunctive cells. Pag benign, remain localized. Malignant, they invade, destroy, and spread. Oma is a general suffix connoting neoplastic processes. They usually connote benign tumors except for lymphoma, seminoma, hepatoma, melanoma, and mesothelioma. Carcinoma, epithelial. Sarcoma, mesenchymal. Lymphoma, lymphoid neoplasm forming distinct tissue masses. Leukemia, hematolymphoid neoplasm, proliferation of neoplastic cells in the bone marrow or peripheral blood. Blastoma, blasts, so primitive cells. Borderline tumor, appearance and behavior between benign and malignant, mixed, more than one line of differentiation. Tas pag teratoma, recognizable mature or immature tissues, more than one germ cell layer. So, meron kang from endoderm, ectoderm, and mesoderm. Hamartoma, kapag disorganized yung cells pero indigenous pa siya dun sa tissue. Corystoma, organized siya pero misplaced siya, nasa ibang lugar siya. So what are the microscopic features of malignancy? You have atypia. Atypia is the degree of disparity of the appearance between the neoplastic cell and its normal counterpart. So kapangitan. So how different is it? How ugly it is compared to the normal counterpart. So you have pleomorphism, which is variation in size and shape. Abnormal nuclear morphology, so abnormally large nucleoli, may hyperchromasia ka. Mitosis, increased mitosis kasi mahilig mag-proliferate yung cancer cells. So meron ka, pero dahil sa sobrang naging bizarre na siya at nagiging atypical. So atypical, bizarre, mitotic figures. Loss of polarity, usually kasi 'di ba? You have your basal cells, your stem cells, nagdi-differentiate sila into yung mature cells. So, nawawalan ng polarity. So, hindi mo na malaman kung asan dyan yung nasa apex, asan dyan yung nasa base na cells. And necrosis dahil nag-outgrow yung neoplasia sa blood supply niya. Next, which proto-oncogene is associated with polycythemia vera? It's JAK2. So, what are your hallmarks of malignancy? You have self-sufficiency in growth signals, insensitivity to growth inhibitory signals, altered cellular metabolism, evasion of apoptosis, limitless replicative potential, sustained angiogenesis, and ability to invade and metastasize. So part dyan yung proto-oncogenes mo. So your common proto-oncogenes would be your, yung mga common dyan would be your EGF receptor family, your ERB. So yung ERB2 sa breast cancer. You have receptor for neurotrophic factors, your RET. Makikita mo siya yung RET sa MEN2A and MEN2B. You have your receptor for KIT ligand, KIT, sa gastrointestinal stromal tumors. And you have your ALK, nakikita mo sa adenocarcinoma of the lung. Other proto-oncogenes, you have your KRAS, nakikita mo yan sa colon, lung, and pancreatic tumors. ABL, ito yung sa chronic myelogenous leukemia, pwede rin sa acute lymphoblastic leukemia. You have your BRAF sa mga melanomas, leukemias. your JAK2 sa myeloproliferative disorders. Kasama dyan yung polycythemia vera. Your MYC and NMYC, nakikita yan sa Burkitt lymphoma, yung NMYC sa neuroblastoma. Yan yung mga common na proto-oncogenes. So you have chronic myelogenous leukemia where there is translocation between chromosomes 9 and 22 becoming your Philadelphia chromosome. This creates a fusion protein known as your BCR-ABL protein. So ABL is a tyrosine kinase that is now under BCR gene control. So etong sa diagram na to, eto siya. So, BCR gene control, which leads to inappropriate expression of ABL kinase activity. So, unregulated siya, leading to increased cellular proliferation. Next, which cannot be achieved using tumor markers alone. The answer here would be detecting malignancy. Assessing response to therapy, yes, ginagamit natin yung tumor markers for that. Detecting tumor recurrence, yes. Screening for cancer, yes. So magkaiba yung screening sa detecting. So pag screening, chinecheck mo lang kung pwedeng meron. Pag sabi kasing detecting, basically nag-diagnose ka. So your tumor markers are substances that indicate tumor presence when present in blood. So you can use it for screening, diagnosis, pero kailangan with other tests. You can check for recurrence, metastasis, and treatment response. You can also use it for staging. So some common ones, you have your HCG for trophoblastic tumors, calcitonin kasi for medullary carcinoma of the thyroid kasi yun naman yung poproduce nun. Catecholamines, pheochromocytoma, your CEA, so carcinomas of the colon. You have immunoglobulins for multiple myeloma, your PSA for prostate, CA125 for ovarian. You have your yung mga TP53, your RAS para sa colon, pancreatic, and lung cancer. Next chapter, infectious diseases. So remember that there's a spectrum of responses to infection. Kasama na dyan yung suppurative. You have your mononuclear and granulomatous inflammation, cytopathic cytoproliferative, tissue necrosis, chronic inflammation and scarring, or pwede namang no reaction. So, kailan nakikita yung suppurative or purulent? Sa mga pneumonia, abscesses, mga bacterial infection, yan. Usually yung mga ganyang bacterial infection. Staph aureus, mga anaerobic bacteria. Mononuclear and granulomatous inflammation, usually sa syphilis and tuberculosis. Cytopathic cytoproliferative, usually for viral infection, so viral transformation of cells. Tissue necrosis, usually kapag may toxins involved or lysis-mediated destruction. Kasama dyan yung sa gangrene ng Clostridium. Chronic inflammation or scarring, pwedeng repetitive injury like in chronic hepatitis with cirrhosis. Pag no reaction, it's usually when you have severe immunocompromise. Next, which is not a member of Paramyxoviridae. The answer is poliovirus. So remember this mnemonic. So your MMR, measles, mumps, pero hindi rubella, respiratory syncytial virus. And para-influenza is part of Paramyxoviridae. Your influenza is part of Orthomyxoviridae. Enteroviruses, another mnemonic, Pecorinavirinae. Yan, Pecorinavirinae. So, polio, echo, Coxsackie, and rhinovirus. Next question, biopsy of a lymph nodes of a child with generalized rash showed multinucleated giant cells with eosinophilic nuclear and cytoplasmic inclusion bodies. Which finding will also be present? Itong statement na to, this is pathognomonic for this disease. These are also called your Warthin-Finkelday cells. This is measles. And yung finding would be your Koplik spot, which are ulcerated lesions near the Stenson's duct. So measles, your etiology is the measles virus. Remember your FCCCR. So fever, coryza, conjunctivitis, cough, and rash. Remember it's cephalocaudal. You have your Koplik spots, which are mucosal lesions near the opening of the Stenson's duct. Common complications would be secondary bacterial pneumonia, encephalitis, etc. And ito, morphology, remember your Warthin-Finkelday cells. So, multinucleated giant cells with eosinophilic, nuclear, and cytoplasmic inclusion bodies. Next, which is not a complication of mumps. The answer here would be myelitis. So myelitis more sa polio. So parotitis, orchitis, and encephalitis, complications yan ng mumps caused by your mumps virus. So parotitis, orchitis, pancreatitis, and encephalitis. So most common extrasalivary gland complication is your aseptic meningitis, sterility, and severe testicular damage. Next, a 7-year-old female was brought to the clinic for generalized vesicular lesions that appear as dewdrops on a rose petal. The lesions most likely started from which area? So to answer this question, ano muna yung sakit? So dewdrops on a rose petal, very telling, this is varicella. Saan na usually nag-start ang rash ng varicella? Sa trunk. So it's the torso. Head, measles. Cephalocaudal. So varicella zoster caused by your varicella zoster virus. So it has a prodrome, dyan yung fever, etc. Then you have your pruritic macular rash, which is centrifugal, so from inside to out. So torso to extremities. Tapos magkakaroon ka na ng vesicles that look like dewdrops on a rose petal. They will rupture and then crust and heal. So different stages of evolution yung rash. So kasama dyan din sa complications ay pneumonia, encephalitis, myelitis, vasculopathy, and necrotizing visceral lesions. Next, a 42-year-old male with no known comorbids came to the clinic for pruritic and painful rashes. 1 week prior to consult, the patient noted tingling and pruritus near his umbilicus. 3 days prior to consult, a painful rash started to develop on the same area accompanied by fever. On physical examination, there are multiple erythematous vesicles found on a band-like region at the level of the umbilicus. No other lesions were seen. What additional information is most likely true? So, meron kang patient na merong band-like region na may multiple erythematous vesicles. Nagkaroon siya ng fever, tapos rash dun sa area na yun. Yung rash dun sa area na yun. This is most likely shingles or herpes zoster. So the correct answer here is there is reactivation of a latent infection affecting the dorsal root ganglion. So hindi siya gram-positive cocci kasi viral infection siya. Hindi na siya magpapakita ng eosinophilia kasi hindi naman siya parasitic. And the rash resulted from a T-cell mediated inflammatory action. Hindi naman siya granuloma. So this is again herpes zoster or a reactivation of latent varicella zoster virus infection in the dorsal root ganglia. So this is common in immunosuppressed patients. So if it occurs in your the distribution of your geniculate nucleus, you will have your Ramsay-Hunt syndrome of facial paralysis, otalgia, and painful auricular vesicles. Remember, dermatomal yung distribution niya. Next, which bacterial infection does not affect the skin in its spectrum of disease? The answer here would be diphtheria. So, nocardia and listeria meron, Microbacteria leprae, diba? So, affected yung skin. Diphtheria hindi. So, this is a list of common bacterial infections. So, sa respiratory, you have strep, diphtheria, bordetella, strep pneumo, strep pyo, strep pneumo, TB, legionella. GI, you have H. pylori, Vibrio, you have E. coli, Shigella, Salmonella, Campylobacter, you have Clostridioides din. Skin and adjacent soft tissue, Staph aureus, Strep pyo, Clostridium perfringens, Bacillus anthracis, Pseudomonas aeruginosa, Mycobacterium leprae. Tapos, yung nocardia and yung listeria, 'di ba ang listeria meron ka nung granulomatosis, granuloma infantiseptica. Yan. So, affected yung skin. Next question, which is true of Mycobacterium leprae infections? Let's go through each choice. Tuberculoid leprosy contains large aggregates of lipid-laden macrophages known as lepra cells. This is incorrect kasi dapat this is lepromatous. Next, lepromatous leprosy is associated with increased interleukin-2 interferon gamma production. This is false, dapat tuberculoid. Pag lepromatous, kalat-kalat na, wala ka ng macrophage masyado, hindi na nako-contain yung infection. Yung macrophage yung pang-contain mo na infection. Hindi niya nagagawa. So, sa tuberculoid tong marami kang interferon gamma production. Immune response against M. leprae involves formation of antigen-antibody complexes which effectively kill the bacteria. Hindi natin na-effectively kill yung bacteria. Hindi yung antigen-antibody complexes yung nag-kill ng bacteria. In fact, kapag mataas yung antibody response mo, hindi mo napapatay yung bacteria. Dapat cell-mediated immunity. So, this is dapat cell-mediated immunity yung against M. leprae. So, the correct answer here is letter D. So, leprosy, the etiology is Mycobacterium leprae. Mainly affects the skin and peripheral nerves. So your lepromin skin test, it tests for the presence of cell-mediated immunity, which is very important in fighting the infection. And you have two spectrums. You have a spectrum of disease. On one end, you have tuberculoid. On the other end, you have lepromatous. So, tuberculoid, basta ibig sabihin nito, contained siya, okay yung response mo. Lepromatous, pangit yung response mo. So, kung maganda yung response mo sa tuberculoid, yung number of lesions mo, konti lang, you just limited to dry scaly lesions, tapos hindi maraming nerves yung involved, morphology mo, paucibacillary siya, meron kang granulomatous lesions kasi nako-contain mo pa. Your granuloma contains the infection. Your cell-mediated response, it's Th1. You produce your macrophages for the granuloma formation. So you have your interferon gamma, your neutrophil and macrophage recruitment, through Th17, etc. Your humoral response is low. Yan, low antibody production. And positive ka pa sa lepromin skin test, which tests for cell-mediated immunity. Kabaliktaran niya sa lepromatous. You have many lesions. Yan, marami ka nang affected na areas. You have multibacillary morphology. You have a lot of lepra cells. It's mostly a Th2 response now. There's high antibody production na wala namang ginagawa. Hindi nila ako-contain. And your lepromin test is already negative. Next, what is the most consistent finding in leptospirosis? It's actually capillary vasculitis. So leptospirosis is caused by Leptospira interrogans. It's a spirochete. You have two phases, the anicteric and icteric phase. So anicteric, non-specific flu-like illness. Sa icteric, ito na yung usual na alam natin, yung renal failure, jaundice, respiratory distress. Ito rin yung tinatawag nating whale disease. The morphology in general is capillary vasculitis. And it's the most consistent pathologic finding. Next question, which pathogen causes donovanosis? The answer here is Klebsiella granulomatis. Chlamydia trachomatis would cause your lymphogranuloma venereum. HPV will cause your genital warts. And your Treponema pallidum will cause your syphilis. So, what is the causative agent of lymphogranuloma venereum? It's Chlamydia trachomatis. So, just a mnemonic for your Chlamydia trachomatis serotypes and the diseases that they cause. So, remember, read your ABCs. Serotypes A, B, and C causes trachoma or infection ng eyelids. Next, Dick. So, serotypes D to K, Dick, lead to STDs. L types cause lymphogranuloma venereum. So, L1, L2, and 3 lead to lymphogranuloma venereum. Next, a 25-year-old female, sexually active, presents with hypogastric pain and mucopurulent vaginal discharge. Gram stain of the discharge showed gram-negative intracellular diplococci. What is the causative agent? So, ito na. Key na yung gram-negative intracellular diplococci. The answer here is Neisseria gonorrhea. Will you be able to see Chlamydia trachomatis in gram stain? The answer is no. Yan, di siya nakikita sa gram stain. Trichomonas vaginalis will not usually present with hypogastric pain and mucopurulent vaginal discharge, as well as your Candida albicans. So for genital discharge, remember chlamydial urethritis and gonococcal urethritis. For chlamydial urethritis, it's actually the most common sexually transmitted infection. So mas common siya kaysa gonococcal infection. But there's no organism seen on gram stain. Gonococcal, second most common. Pero, makikita mo na siya sa gram stain. Gram-negative intracellular diplococci on gram stain. What is the cause of severe manifestations of rickettsial infections? The answer here would be infection of endothelial cells leading to endothelial dysfunction and injury. Next question, which is a characteristic of typhus fever? Remember, this is typhus, not typhoid fever. So, mali na agad lahat nung iba. Mali na si A, mali na si B, mali na rin si D. Yung A, B, and D, they're talking about typhoid. And this is typhus, which is a rickettsial infection. And yun nga, sabi natin na yung manifestations are mostly infection of endothelial cells. So you have small vessel lesions and focal areas of hemorrhage and inflammation. So rickettsial infections, they're caused by vector-borne obligate intracellular bacteria. Again, yung manifestations are due to infection of endothelial cells. So a lot of them would present with hemorrhage, like hemorrhagic rash. So you have epidemic typhus, scrub typhus, and Rocky Mountain spotted fever. Just remember yung mga vectors nila. Sa epidemic typhus, it's your body lice. Scrub typhus, it's mites. And for Rocky Mountain spotted fever, it's dog ticks. Next, let's go to environmental and nutritional diseases. A 4-year-old female was brought to the health center for Operation Timbang Plus. On physical exam, there is reduced circumference of the mid-arm and an enlarged liver. What other finding will differentiate this disease from other forms of severe acute malnutrition? So dahil dito sa reduced circumference of the mid-arm, na-confirm natin si severe acute malnutrition. Anong point ng enlarged liver? So dapat, alam na natin by this time na this is talking about kwashiorkor. Ngayon, ang tinatanong, alin dito sa mga choices yung magde-differentiate, yung more kwashiorkor than the other forms? The answer here would be generalized edema. Kasi si microcytic anemia at si vitamin deficiency ay pwede sa both. And yung head appears too large for the body ay sa marasmus. So sa severe acute malnutrition, it results from inadequate protein and caloric intake. So may two opposite spectrums ka kapag mas malaki yung deficit sa protein intake or sa caloric intake. Marasmus, mas malaki yung total calories deprivation. Kwashiorkor, mas malaki yung protein deprivation. Remember, your protein has two compartments. Somatic, mostly sa skeletal muscle, visceral sa liver. And this table summarizes the differences. So, dahil si marasmus, mas marami kang total calorie deprivation, gusto mo i-save si visceral component. So, mas affected si somatic component. So, si serum albumin levels, normal or slightly reduced lang. Ang effect, sobrang emaciated ng extremities mo and your head appears too large for your body. Si kwashiorkor, wala kang protein na ini-intake, pero nakakain ka naman. So, hindi mo kailangan gamitin yung muscle mo for energy. So, ang nag-suffer dyan ay yung visceral component mo. So, yung serum albumin levels mo, greatly reduced. So, yung itsura mo, may generalized edema ka dahil sa hypoproteinemia. You have flaky paint skin, you have hair changes, you have an enlarged fatty liver. You also have apathy, listlessness, and loss of appetite. For both, dahil sa malnourished ka nga, you have micronutrient deficiencies, defects in immunity, multifactorial anemia, and thymic and lymphoid atrophy. Next, craniotabes is seen in which deficiency state? The answer here is vitamin D. If you know craniotabes, it's a bone defect, and bones are usually related to vitamin D. So, micronutrient deficiencies, this table summarizes the common ones and the syndromes which they present with. So you have your fat-soluble vitamins here. Vitamin A deficiency, night blindness, xerophthalmia. You have squamous metaplasia. You have vulnerability to infection, particularly measles. Vitamin D, you have rickets in children and osteomalacia in adults. And dyan magmamanifest yung craniotabes. Vitamin E, spinocerebellar degeneration, hemolytic anemia. Vitamin K, important in clotting. You have bleeding diathesis. Sa mga water-soluble, B1, beriberi, Wernicke and Korsakoff syndrome, and chronic alcoholics. Vitamin B2, you have your cheilosis, stomatitis, glossitis. Niacin, you have your pellagra, the 3Ds, dementia, dermatitis, and diarrhea. B6, you also have cheilosis and glossitis. and peripheral neuropathy. B12, it's megaloblastic pernicious anemia. Ito yung cobalamin mo. Vitamin C, it presents with scurvy. Folate, you will also have megaloblastic anemia and neural tube defects. Your pantothenic acid and biotin, di masyado pa alam. For your trace elements, your zinc, ito yung sa rash. Iron, hypochromic microcytic anemia. Iodine, goiter and hypothyroidism. Copper, it's important in collagen, the collagen synthesis and formation. So abnormal collagen cross-linking. Fluoride, dental caries. Selenium, it produces myopathy and cardiomyopathy, your Keshan disease. So in vitamin D deficiency, kapag bata na hindi pa nagko-close yung epiphysis, causes rickets. Pag matanda, osteomalacia. It leads to excess of unmineralized matrix. So in rickets, kapag non-ambulatory stage of infancy, ang affected ay yung head and chest. Sa head, meron kang craniotabes, which is flattening of the occipital bones. Meron ka ring frontal bossing. Sa chest naman, dito makikita yung rachitic rosary and your pigeon breast or pectus carinatum deformity. Pag nag-ambulate na, yung affected na ay yung spine, pelvis, and tibia. So, merong lumbar lordosis and bowing of the legs. A 29-year-old female was brought to the ER for psychosis and ataxia. History reveals excessive alcohol intake and alcohol dependence over the past 5 years. If the patient is left untreated, which irreversible symptom may develop? The answer here is confabulation. This is talking about Korsakoff syndrome. So the toxic effects of ethanol metabolism are due to the acute effects of acetaldehyde, the oxidation of alcohol leading to reduction in NADH, which lead to fatty liver and lactic acidosis, and your reactive oxygen species generation. In acute alcoholism, it mainly affects your CNS. It also affects your liver, and it also affects your stomach. But in chronic alcoholism, marami na affected. Your liver, your gastrointestinal tract, your brain, your cardiovascular system. It affects the fetus. Kung yung mother yung uminom na alcohol, leads to fetal alcohol syndrome. Affects your pancreas. It's a carcinogen, and it also leads to malnutrition. Micronutrient deficiencies, especially vitamin B1 or thiamine. And the thiamine deficiency will lead to your Wernicke-Korsakoff syndrome. First is Wernicke encephalopathy, which consists of acute psychosis and ophthalmoplegia. It is reversible with thiamine treatment. Pero pag tuloy-tuloy pa rin, it may lead to Korsakoff syndrome, which lead to disturbances of short-term memory and confabulation, which is prolonged and irreversible. So, just a mnemonic, weird ako, kaya mas cool. Weird ako, weird kasi nagsa-psychosis. Weird ako. So, Wernicke, ataxia, confusion, ophthalmoplegia, kaya mas cool. K. Korsakoff, memory loss, and confabulation. Last, diseases of infancy and childhood. So, which is not an environmental cause of congenital anomalies? The answer here is chromosomal aberrations because this is genetic. The others are environmental. So, your congenital anomalies, ibig sabihin ng congenital, present at birth. Kapag malformation, primary errors of morphogenesis, disruption, secondary destruction of a normally developed organ, deformation, and extrinsic disturbance. Sequence is a cascade of anomalies like your Potter sequence or oligohydramnios sequence. Malformation syndrome is a constellation of congenital anomalies, but they cannot be explained by a single localized initiating defect. So etiologies, disruption, etiologies, a lot of it is unknown. Yan. Most common. Pag tinanong most common cause of congenital anomalies, it's still unknown. Kung hindi naman unknown, yung next ay multifactorial. Yan na yung next. And last question, a couple came to a reproductive clinic seeking consult for infertility. Upon interviewing the 30-year-old male Caucasian partner, there is a history of recurrent lung infections, distal intestinal obstruction, and recurrent acute pancreatitis. On further investigation, the male has azoospermia, which is the least likely finding. So this is a case of cystic fibrosis. And in cystic fibrosis, tuyong-tuyo ang mucus mo. So the answer here is excessive watery mucus production. Morphologically, normal pa rin ang sweat glands mo. You will have fat-soluble vitamin deficiency and you will have lung abscesses. So in cystic fibrosis, it is a disorder of ion transport that affects fluid secretion in the respiratory, GIT, and reproductive tracts. There's a mutation of your CFTR gene and tissue-specific yung function niya. Sa sweat gland, it reabsorbs chloride and aid in sodium reabsorption. Sa respiratory, GIT, and pancreas, it's active luminal chloride and bicarbonate secretion. So ano nangyayari? Sa cystic fibrosis, kapag sa sweat gland, ang nangyayari, there's increased sodium chloride concentration in the sweat kasi hindi ka nakaka-reabsorb ng chloride and sodium. Sa airway naman, hindi ka nakaka-secrete ng chloride leading to excess na sodium reabsorption na yung sodium reabsorption mag-lead siya to excessive water reabsorption na hindi nalalabanan ng chloride na lumalabas. So, very dehydrated yung mucus mo. So, sa sweat glands, it will result in salty sweat. Sa mga respiratory, GIT, and pancreas, you will have viscous mucus and mucus plugs and infections. Yung decreased bicarbonate secretion naman, it will cause acidic secretions which lead to increased mucin precipitation and bacterial adherence to mucus plugs. So the morphology is mucus plugs in the pancreas, salivary glands, intestine, liver, and lung. So you'll have inflammation due to infections. In the pancreas and salivary glands, you'll have dilated ducts. But remember, your sweat glands are normal. There's also congenital bilateral absence of vas deferens. Clinical features. So your sine qua non is salty sweat dahil sa increased sweat chloride levels. Pulmonary infections are the most serious manifestation. Your exocrine pancreatic insufficiency will lead to maldigestion and fat-soluble vitamin deficiencies. Azoospermia and infertility in patients without vas deferens. But remember, your most common cause of death would be cardiorespiratory complications. So that's it for general pathology. Thank you.